right now, there are over 1 billion people worldwide walking around with high blood pressure.
Yeah, it's a staggering number, honestly.
It really is. And to fix it, tens of millions of those people rely on a daily pill from this class of drugs known as angiotensin receptor blockers, or ARBs.
The sartans.
Exactly, the certain. So, if you look in your own medicine cabinet, you might recognize names like losartan, valsartan, irbesartan. And if you're like most people, you probably picture these pills working kind of like a blunt instrument.
Like putting a clamp on a garden hose, basically.
Right, you just squeeze the pipe, the pressure drops, and, well, you call it a day.
Which, to be fair, is the default assumption for most of us. I
Yeah.
mean, we look at the number on the blood pressure cuff, we see it go down, and we just assume the drug is mechanically relaxing the plumbing.
But it's not that simple, is it?
Not at all. When you examine the actual pharmacological history and the microscopic biology here, that blunt clamp turns out to be a highly sophisticated, targeted lockpicking tool.
Which is the core mission for this deep dive today. We are taking a big stack of pharmacological notes, historical timelines, and massive clinical trials to uncover what ARBs actually are.
Because this is so much more than a simple blood pressure story.
Yeah, it's a look at how a drug evolved from being, just a tolerable alternative into a targeted organ-protecting powerhouse. So, okay, let's unpack this, because if you looked at a medical textbook from the late 1990s, the baseline definition of an ARB was basically just, well, it was defined as an ACE inhibitor without the cough.
Yeah, and that framing is incredibly outdated today. But, you can understand why it started that way.
Because they came second.
Right. ARBs were developed after ACE inhibitors, so they were initially viewed as this downstream cousin, a slightly more tolerable version of an already established drug.
But modern pharmacology has totally shifted that paradigm, right?
Completely. We now classify ARBs as targeted renin-angiotensin-aldosterone system modulators, or RAS modulators for short.
RAS modulator.
Yeah. And while they do lower blood pressure, they also actively protect the architecture of your kidneys, your heart, and your brain in ways that, frankly, have nothing to do with the numbers on that blood pressure monitor.
Wow. Okay. So to understand what these drugs are actually doing inside you today, I think we have to look at the problem scientists were trying to solve decades ago.
Oh, absolutely. The origin story.
Yeah, the origin story of the ARB class is essentially a story of learning from a massive failure. Like, in the 1970s, researchers developed this drug called psorallicin.
Psorallicin. It was theoretically brilliant, but clinically just totally useless.
How so?
Well, it was a peptide, basically a synthetic analog of the body's own hormone, angiotensin II. The idea was to introduce this peptide to block the specific receptor that angiotensin II binds to the AT1 receptor.
And did it work?
I mean, in a vacuum, yeah, it worked. It proved the concept that blocking this receptor could lower blood pressure. But peptides come with a severe structural flaw if you want to use them as a daily medication.
Because of digestion.
Exactly. If you swallow a peptide, your stomach acid and digestive enzymes just treat it like a piece of steak.
Oh, wow. So they just break it down for energy before it ever even reaches the bloodstream.
Right. So psorallicin had to be administered intravenously.
Which is insane for blood pressure. You can't ask a patient with chronic high blood pressure to just, hook themselves up to an IV every single day.
You really can't.
Okay.
And on top of that logistical nightmare, psorallicin acted as a partial agonist.
Okay, let's break that down, because a partial agonist sounds like a contradiction. If I understand this correctly, you take the drug to block the receptor, but occasionally the drug itself accidentally triggers the receptor it's supposed to be blocking.
That is the perfect way to describe it, yeah.
So you might take a pill to lower your blood pressure, and it accidentally spikes your blood pressure instead.
Exactly. It's like trying to jam a piece of metal into a lock to prevent the door from opening. But the metal accidentally turns the tumblers and opens the door anyway.
That sounds like a terrible drug.
It was. So psorallicin was a dead end, but it proved the target was viable, and that sparked this global relay race. In the early 1980s, scientists at Takeda Chemical Industries in Japan discovered two weak structural compounds that could block the receptor without being peptides.
The SA307 and SA308 compounds, right?
Yes. They weren't potent enough to be actual drugs, but Takeda published the research anyway.
And this is where the baton gets passed across the world, because chemists at DuPont Merck Pharmaceuticals in Delaware, specifically David Carini and Joseph Dancia, They read the Takeda research.
Yeah, they used those weak compounds as a structural spanning point and spent years optimizing them.
But I have to stop here and ask a sort of business and logic question.
Okay, shoot.
If I'm a pharmaceutical executive in the late 1980s, we already have captopril. The first ACE inhibitor was approved in 1981, and it worked beautifully to lower blood pressure. So why am I pouring millions of dollars and years of research into a completely untested receptor blocker when the problem seems to be solved?
Well, because the problem wasn't entirely solved. The ACE inhibitors had a massive Achilles heel.
The cough.
Right. They were incredibly effective at preventing heart attacks and lowering pressure, but they caused a dry, hacking cough in about 5 to 20% of the people who took them.
And we aren't talking about, like, a mild tickle in the throat here, are we?
No, not at all. This was a chronic, exhausting, keep you up at night kind of cough. Patients were simply abandoning their life-saving medication because they couldn't sleep.
Which renders the drug completely useless. I mean, it doesn't matter how good the pharmacology is if the patient refuses to swallow the pill.
Exactly. And beyond the cough, there was a second, much rarer, but far more terrifying limitation, angioedema.
Oh, right. The swelling.
Yeah. It's a severe, rapid swelling of the deeper layers of the skin, often around the face, lips, and throat. And the scary part is, it could happen completely unpredictably.
Wait, really? Like, even if you've been taking it for a while?
Sometimes years after someone had been safely taking an ACE inhibitor. And if that swelling compromises the airway, it becomes a fatal emergency.
That is terrifying.
It is. So the researchers at DuPont Merck wanted to preserve the massive cardiovascular benefits of blocking this system, but they needed a chemical workaround to sidestep those exact side effects.
And that effort finally resulted in a compound called DP-753, which the FDA approved in 1995 as losartan, the world's first ARB.
That's right, the first of the sartans.
So knowing why ARBs were created leads us directly into how they actually avoid the cough and the swelling. And to visualize that, I think we need to take a quick trip into human plumbing.
Let's do it.
We need to look at the RAS cascade. How does this system actually work when we aren't taking any drugs?
Well, it's a beautiful cascading domino effect. It's designed to keep you from passing out if you get dehydrated or lose blood.
Okay.
So when your body senses a drop in blood pressure or fluid volume, your kidneys release an enzyme called renin.
All right, renin.
Renin travels into the bloodstream and finds a protein made by your liver called angiotensinogen. Renin cleaves that protein, it just snaps off a piece, to create a new molecule called angiotensin I.
But angiotensin I is basically inert, right? It's just floating in the bloodstream waiting for the next step.
Correct. The real transformation happens when angiotensin I circulates through the microscopic blood vessels in your lungs. Sitting on the walls of those vessels is the angiotensin-converting enzyme, or AC.
Hence, ACE inhibitors.
Exactly. As angiotensin I floats by, the ACE enzyme grabs it and converts it into angiotensin II.
And angiotensin II is the main character of this entire deep dive.
It is the primary effector. Angiotensin II hunts down a specific doorway on your cells called the AT1 receptor.
And when it finds it, when
Yeah.
it binds to that AT1 receptor, it wreaks havoc on a grand scale. It causes your blood vessels to violently constrict, which artificially drives up pressure.
Like squeezing the hose. Yes. And it also signals your adrenal glands to release a hormone called aldosterone, which forces your kidneys to hoard sodium and water, increasing blood volume and driving pressure up even further.
Wow.
And over the span of months and years, it drives fibrotic remodeling. It essentially scars and stiffens the heart muscle and the blood vessel walls.
Okay, so looking at that whole chain of events, let's use an analogy to make sense of the difference between the older ACE inhibitors and the newer ARBs.
I love a good analogy.
So imagine that angiotensin II is a dangerous master key that starts up a destructive machine in your body. An ACE inhibitor works by shutting down the key factory upstream.
Right, it binds to the ACE enzyme in the lungs.
Yeah, and it stops it from ever manufacturing the keys in the first place. But an ARB, an angiotensin receptor blocker, does something completely different. It just changes the lock on the machine itself downstream.
Exactly.
The factory is still running, the keys are still being minted, and they're floating around in the bloodstream, but they just can't fit into the machine anymore.
That is a phenomenal way to visualize the mechanism. And the reason that difference matters, the reason changing the lock is better than shutting down the factory for some people. Well, what's fascinating here is it comes down to a strange biological quirk.
Oh, the moonlighting enzyme?
Yes, the ACE enzyme in your lungs has a moonlighting gig. It's known biologically as kinase to 2. So while its primary job is making the dangerous angiotensin II keys, its second job is breaking down an inflammatory protein called bradykinin.
Okay, so it's multitasking. It creates a blood pressure hormone, but it acts as the garbage disposal for this inflammatory protein.
Right. So when you take an ACE inhibitor, you shut down the factory completely, you stop making angiotensin II, which lowers your blood pressure, but you also jam the garbage disposal.
Because it's the exact same enzyme.
Exactly. You stop breaking down bradykinin. So bradykinin starts to pool and build up in the lung tissue. This excess bradykinin sensitizes the vagal nerve endings in your airways.
And that is what triggers the dry, hacking cough.
Yes. And that buildup is also what causes the dangerous swelling of angioedema we talked about earlier.
I just love when a confusing side effect has such a clear mechanical cause. And because ARBs just change the lock downstream at the receptor, they never touch the ACE enzyme.
Right. The factory keeps running.
Which means the garbage disposal keeps running. The enzyme keeps breaking down bradykinin, so you never get that inflammatory buildup in the lungs.
Which is why clinical trials show that ARBs offer placebo-level rates of a cough. It's a genuinely different chemical intervention operating on a totally different level of the cascade.
And changing the lock offers another major advantage over closing the factory, doesn't it? The sources talk about a phenomenon called ACE escape.
Oh, ACE escape is a huge factor. If you rely entirely on blocking the ACE enzyme, you have to remember that the body is incredibly stubborn.
It wants that blood pressure to stay up.
Exactly. It wants that angiotensin II to keep blood pressure up, so it simply finds back doors. It utilizes entirely different enzymes like cammase or cathepsin G to manufacture the keys anyway.
Wait, really? It just builds a new factory?
Pretty much. Roughly 40% of the body's angiotensin II can be generated through these non-ACE enzymatic pathways, especially locally inside the heart tissue.
That's incredible.
So over time, a patient on an ACE inhibitor might see their hormone levels slowly creep back up. But ARBs bypass this problem entirely. Because they block the AT1 receptor itself, it genuinely doesn't matter who manufactured the key or which backdoor enzyme pathway the body used, the lock is jammed.
But wait, hold on. I want to push back on this logically for a second.
Okay, sure.
If I am the human body and my AT1 receptors are suddenly jammed, wouldn't my internal alarms go off?
How do you mean?
Like, if the keys can't get in, my body isn't getting the signal that blood pressure is stable? Wouldn't the body panic, remove the brakes, and just start producing way more of the hormone to try and force the door open?
You've just walked right into one of the most brilliant plot twists in pharmacology. Yes, that is exactly what happens. Under normal conditions, angiotensin II uses that AT1 receptor to send a negative feedback signal back up to the kidneys, saying, okay, we have enough pressure, you can stop making renin now.
So the feedback loop.
Right. When you introduce an ARB and block AT1, you sever that feedback loop entirely. The body thinks it's starving for pressure. Renin release skyrockets, and the levels of angiotensin II in the blood can actually rise dramatically.
But wait, so if you take this pill, you end up with massive amounts of this dangerous unblocked hormone just floating around in your bloodstream? How is that not a disaster for the patient? Where does all that extra hormone go?
Well, it can't go to the AT1 receptor because the ARB is sitting there like a bouncer blocking the door.
Right.
But humans have a second doorway, the AT2 receptor.
Oh.
Yeah, and ARBs are highly selective. They only block AT1, and they completely ignore AT2. So all of this excess angiotensin II gets redirected. It floods the AT2 receptors instead. Yeah. And here is the kicker. Stimulation of the AT2 receptor does the exact opposite of AT1.
So it's not destructive.
Far from it. AT2 stimulation promotes vasodilation. It actively relaxes the blood vessels.
Wow.
It triggers the release of nitric oxide. It has anti-proliferative and anti-fibrotic effects, meaning it stops the tissues from scarring. Pharmacologists refer to this dynamic as unopposed AT2 stimulation.
That is wild. It's not just passively stopping the bad stuff. It's actively tricking the body into rerouting its own hormones to do good stuff.
It's a bonus mechanism that no one initially planned for, but it helps explain why ARBs perform so remarkably well when it comes to long-term organ protection, far beyond just lowering the numbers on a cuff.
And if we follow that logic, it explains why the medical community had to expand the definition of ARBs. I mean, they couldn't just be categorized as blood pressure pills anymore.
Right, they had to look deeper.
Let's look at the actual clinical trials that prove this tissue protective bonus mechanism, starting with the LIFE trial in 2002.
Ah, the LIFE trial. It fundamentally changed how we view these drugs. The researchers took about 9,000 patients with high blood pressure and left ventricular hypertrophy.
Meaning their heart muscles had thickened dangerously from years of pumping against high pressure.
Exactly. They randomized them into two groups. One took losartan, an ARB, and the other took atenolol, which is a standard beta blocker.
Okay.
Throughout the study, the blood pressure control was nearly identical between the two groups. The garden hose was unglamped to the exact same degree.
Right, so if the pressure is identical, you would logically expect the health outcomes to be identical.
But they weren't. The patients taking the ARB experienced a 25% greater reduction in the rate of stroke compared to the beta blocker group.
Here's where it gets really interesting. A 25% drop in stroke risk just from swapping the mechanism of the drug, even though the final blood pressure number was exactly the same.
It was undeniable proof that blocking the AT1 receptor protects the blood vessels in the brain in ways that simple hemodynamics cannot explain.
Wow.
And we saw a similar revelation regarding the kidneys in 2001 with renal and ID&T trials. Those trials focused on diabetic patients who already had significant kidney damage.
And what did they find?
The data showed that losartan and irbesartan slow their decline into total kidney failure, independent of the drug's blood pressure-lowering effects.
But how? How does changing a lock in the RAS system physically save a kidney from failing?
To understand that, you have to picture the filtering unit inside the kidney, called the glomerulus. Think of it like a microscopic, delicate sieve that cleans your blood.
Okay, I'm picturing a sieve.
Blood goes in through an entry vessel, gets filtered, and leaves through an exit vessel called the efferent arteriole. When a patient has kidney disease, the pressure inside that sieve gets dangerously high, forcing vital proteins to leak out into the urine and scarring the delicate tissue.
Oh, it's like putting your thumb over the end of a hose, causing the hose itself to just bulge from the trapped pressure.
Exactly like that.
Yeah.
And angiotensin II is the thumb. It specifically targets and constricts that exit vessel, the efferent arteriole.
Ah, I see.
So when you give a patient an ARB, you block that constriction. The exit vessel dilates, the exit valve opens up, and the mechanical pressure inside the delicate sieve drops immediately. It stops the protein leakage and halts the scarring.
That's brilliant. And if opening that exit valve in the kidney works so well, what happens if we apply that logic to a failing heart?
That leads us directly to the next evolution of this drug class in 2014 with the PARADIGM-HF trial.
Right, this trial introduced a completely new drug class called ARIs. They took valsartan, a standard ARB, and physically combined it with a neprilysin inhibitor, creating a drug called sacubitril/valsartan. So why add a neprilysin inhibitor?
This is where we start layering benefits. Neprilysin is an enzyme in the body that degrades natriuretic peptides.
What do those do?
Well, natriuretic peptides are essentially your body's natural defense mechanism against heart failure. They promote the excretion of sodium and fluid, relieving strain on the heart. But under normal circumstances, neprilysin comes along and destroys these helpful peptides.
So a neprilysin inhibitor stops the destruction. It keeps the good peptides circulating longer.
Correct. But if you just use a neprilysin inhibitor alone, the body compensates in ways that aren't helpful.
Oh, of course it does.
Right. But when you combine it with an ARB, blocking the destructive AT1 receptor while simultaneously boosting the helpful natriuretic peptides, the synergy is incredible.
It was a massive success, wasn't it?
It was. The PARADIGM-HF trial actually had to be stopped early because the combined drug so vastly outperformed standard ACE inhibitors in keeping heart failure patients alive. It became a modern first-line therapy, cementing the ARB mechanism as the foundation for the future of cardiovascular medicine.
Hearing all of this incredible success, a very obvious medical hypothesis jumps out at me.
Let me guess. Combining them.
Yeah. If shutting down the factory with an ACE inhibitor is good and changing the lock with an ARB is good, well, why not give the patient both pills at the same time? Double the blockade, double the benefit.
It is a totally seductive theory. Mechanistically, dual blockade sounded like a cure-all. But this is where we get a massive cautionary tale in modern medicine.
Why? What happened?
You can never reason purely from mechanism without real-world outcomes data. When researchers finally tested this dual therapy at scale, combining an ACE inhibitor and an ARB in the on-target trial in 2008, and later the VA Nephron-D trial in 2012, the results were devastating.
Devastating. What happened to the patients?
There was absolutely zero added cardiovascular benefit. The dual therapy didn't prevent any more heart attacks or strokes than a single drug, but the harms skyrocketed.
Oh, no.
Patients experienced significantly more severe hypotension, meaning their blood pressure crashed to dangerous levels. They developed hyperkalemia, which is a buildup of potassium in the blood that can literally stop the heart from beating.
That's terrifying.
And most shockingly, there was a massive spike in acute kidney injury, With some patients suffering such rapid kidney failure, they required dialysis.
So doing both completely overwhelmed the body's ability to regulate itself.
It just paralyzed the system. Today, clinical guidelines worldwide are incredibly strict about this. ACE inhibitors and ARBs should essentially never be prescribed together in routine practice.
That is a terrifying example of logical deduction going horribly wrong in a clinical trial.
It really is.
But we saw a very similar logical trap play out on a global scale just recently, in 2020, with the outbreak of COVID-19. Suddenly, ARBs were front-page news.
Yeah, this was a perfect storm of biological nomenclature causing widespread clinical panic.
Because of the names.
Right. Early in the pandemic, virologists discovered that the SARS-CoV-2 virus enters human cells by latching onto a specific receptor on the cell surface called ACE2. Now, ACE2 is a completely different enzyme from the ACE we've been talking about, but the names are obviously very similar.
And then researchers noticed a concerning pharmacological detail, right? Like if you put someone on an ARB, their body might actually upregulate or increase the total number of these ACE2 receptors in their tissues.
Exactly. You can see why the immediate logical leap was terrifying. If these widely prescribed drugs create more of the very doorway the virus uses to enter cells, are we rolling out the red carpet for COVID-19 in tens of millions of vulnerable heart patients?
Should we take everyone off their blood pressure medicine?
That was the fear. Some clinicians panicked and actually started doing exactly that, removing patients from life-saving therapies.
But when we finally got the massive observational data, what did it show?
It showed the exact opposite of the fear. Large-scale studies and rapid guidelines from the American Heart Association and the European Society of Cardiology proved there was absolutely no harm in staying on ARBs.
Not at all.
None. In fact, some emerging data suggested that the ACE2 receptor itself might be protective against the severe inflammatory lung injury caused by the virus. It was a vivid, real-time example of how a singular biochemical fact can generate totally unsupported clinical fear if you don't step back and look at the whole picture.
And it highlights just how deeply these drugs are embedded in our society. I mean, if tens of millions of people are relying on them every single day, any disruption is a global crisis.
Absolutely.
Which brings us to a disruption that had nothing to do with human biology and everything to do with industrial manufacturing. In 2018 and 2019, millions of these pills were suddenly pulled from pharmacy shelves worldwide.
I think that was a mess.
If the pharmacology wasn't the problem, what was?
This is a crucial lesson that highlights the vulnerabilities of our global medicine supply. In mid-2018, regulators started recalling massive lots of generic valsartan and later losartan and irbesartan.
Oh,
During routine testing, they had detected probable human carcinogens chemicals known as NDMA and NDEA inside the pills.
okay, but to be explicitly clear for anyone listening right now, this wasn't a flaw in the ARB molecule itself, right? Like valsartan does not cause cancer.
Correct, yes. The pharmacology of the drug was perfectly safe. The issue was entirely a supply chain and quality control failure. Investigators traced the contamination back to a specific Chinese supplier, Zhejiang Huahai Pharmaceutical.
And they supplied a lot of people.
They supplied the raw active pharmaceutical ingredient for many generic drug makers worldwide. They had altered their chemical synthesis process to make manufacturing more efficient. And that specific new chemical process inadvertently created these carcinogenic byproducts.
And because the active ingredient was shipped globally to different generic packagers, it became one of the largest pharmaceutical recalls in modern history.
It did. And it serves as a stark reminder that a drug's safety relies just as much on its manufacturing process as it does on its mechanism of action in the body. Just because a drug is labeled generic does not mean the manufacturing process is identical or interchangeable without strict, rigorous oversight.
Right. The process matters just as much as the molecule. So what does this all mean for you? If you look in your medicine cabinet tomorrow morning and see one of these sartans, or if you're just someone fascinated by how modern medicine actually works, the journey of this drug class is incredible.
It really is a triumph of pharmacology.
Yeah. ARBs are a backbone therapy. They aren't a downgrade, and they aren't just weaker ACE inhibitors. They are a distinct, highly engineered lock change in your body's cardiovascular system. They don't just lower the pressure in the pipes, they protect the heart from thickening, they protect the brain from strokes, and they release the dangerous pressure valves inside your kidneys.
You know, I think the most beautiful takeaway from the source material is the sheer elegance of that unopposed AT2 stimulation we discussed.
Oh, yeah.
By simply putting a blocker in front of the body's destructive pathway. The AT1 receptor, the ARB, doesn't just halt the damage. It actively forces the body's excess hormones down a different hidden pathway, the AT2 receptor, that actually heals and protects the tissues.
It's amazing.
It's essentially an accidental form of pharmacological judo. You're using the body's own momentum, its own overproduction of a hormone, to cure itself.
Pharmacological judo, I love that. It's a long, long way from just putting a clamp on a garden hose. Thank you for joining us on this deep dive. Keep questioning the science behind the everyday items in your medicine cabinet, because clearly even the most common pills have a masterclass in biology hiding inside them. See you next time.